along homecoming that just happened this past weekend. Truly a remarkable effort. I'd like to say that Marissa was the only reporter as they started their trek. And again, as that story gained momentum as they traveled more than 2,300 miles over 100 days to DC to make their statement of peace. So again, congratulations to the Fort Worth Report newsroom. Great job. I'd now like to ask Dr. Emily Messer, our venue sponsor, to come to stage and share some opening remarks with us.
Thank you, Mike. Good morning. Welcome to Texas Wesleyan University. We are delighted that you're here with us this morning here in the Paul and Judy Andrews Ballroom in the Martin University Center. So it is a wonderful time here at Texas Wesleyan. We actually are celebrating our 135th year as the first university founded in the city of Fort Worth. So wonderful, yes, applause. And in addition to celebrating this historical year, we also made history this fall semester with our largest freshman class in the university's history. So in addition to that, a 10% overall increase in enrollment. So many great things going on campus, but today as we are recognizing the medical industry and healthcare, I want to give you a few updates on our healthcare programs here on campus. So we actually have a 44-year-old Doctorate of Nurse Anesthesia Practice program. You may be aware of that. It is actually the largest nurse anesthesia program in the country. We have students from all over the country coming here, and they actually go out and do clinical sites in 9 different states across the country as well. So if you know of anyone interested in nurse anesthesia, send them to us. We will be happy to answer any questions that they may have. We also have a family nurse practitioner program. So all of our healthcare programs are graduate, either master's or doctoral programs, but we are interested in expanding healthcare options. So we are actually posting, well, it's posted currently, a Dean of Health Professions, so that we can look at expanding our healthcare programs at the university. So if you know of anyone interested in getting into academia and wants to be a Dean of Healthcare, Health Professions programs, please let us know. We would be happy to answer their questions as well. But we are delighted to serve East Fort Worth and the city of Fort Worth, and thank you to Fort Worth Report for hosting this event on campus today. I know it will be a wonderful time, and thank you for our panelists for being here today as well. So have a wonderful day, and thank you for being at Texas Wesleyan.
Thanks very much, Emily, for those words. And again, thanks again for being our venue sponsor. This is such a lovely facility to bring you all together this morning. We're also incredibly thankful for our sponsors who make this morning's event possible. So this morning I'd like to start out with a shout out to North Texas Community Foundation. They're our series food sponsor. Hopefully you all found the food out there. Some really great breakfast burritos. Also, Mental Health Connection, a series sponsor. Real Estate Council, series sponsor. United Way, also a series sponsor. Hoffer Walker, a silver sponsor. If our sponsors would please stand for a round of applause to show our gratitude for their support. Without their support, this series where we convene to discuss community-centered dialogue would not be possible. And if you're interested in learning more about sponsorship opportunities with the Fort Worth Report, I'd like to introduce you to Jody Newton, our Director of Corporate Community Relations. Jody works with companies and community partners that align with our brand with impactful local journalism and civic engagement. Jody, she already stood, so thank you, Jody, for beating me to the punch and asking you to stand. She's also available afterwards if you would like to speak with her. One other note, I want to share a milestone since our last Candid conversation. The Fort Worth Report recently surpassed 106,000 newsletter subscribers. So, fantastic. That's the work of a lot of effort and planning. Certainly again, without all 24 employees of the Fort Worth Report, that would not be possible. We're proud of our growth because it reflects the community that values trusted local journalism. And one last plug, if you're not yet a member of the Fort Worth Report, we'd love you to join the movement. You can scan the QR code on the screen as it rotates to learn more about becoming a member and supporting our work. And if you'd like to talk with someone directly, our membership manager, Ella Scott Dean. Ella, would you stand and give us a wave? She's available to help talk to you about the different levels of membership and how you can be involved. Thanks, Ella. One other thing that we have, as a nonprofit, we're always doing things in terms of raising revenue to support our journalism. We do have an Eats book, which is filled with 13 local restaurants that offer $20 coupons. Those are available. You can see Jody afterwards if you're interested in getting one of those. So today's topic, soaring cost of healthcare, really affects every one of us in this room. At the Fort Worth Report, our mission is to provide in-depth, nonpartisan journalism that helps our community better understand complex issues like this one and create opportunities like today where we can come together to discuss them. Thank you so much for being here, for caring about this issue, and supporting local journalism in Tarrant County. Now I'd like to introduce our health reporter, Ismael Belkoura, to get us started. Ismael, if you'll come on up. Ismael started out as a fellow with the Fort Worth Report. And after his very successful fellowship, he went off to Northwestern where he got his master's degree. After he got his master's degree, he decided he didn't like cold weather. He came back to Fort Worth, and he's here today, and again, he's done just a super job providing great health coverage for Tarrant County, and he'll be our moderator today. Ismael?
Thank you so much, Mike. I'd like to now invite to the stage the stars of the show. We got Dr. Jeff Beeson, Dr. Stuart Pickell, Ali Lehman, and W. Stephen Love. I think your mics might be off, so just so you guys know before you answer questions. I introduce you guys by name, but if we kind of can go from my side to you guys, of just introducing yourselves and kind of what you guys do.
Sure, so my name is Jeff Beeson. I am an emergency physician by training, but quite a confused soul. I started here in Fort Worth over 30 years ago as a paramedic at MedStar. Then became a registered nurse. Spent years working on our health systems here in Fort Worth, ultimately working for CareFlight as a flight nurse. And then ultimately went back to medical school at the Texas College of Osteopathic Medicine here at UNT Health. Then I trained at emergency medicine at Parkland, Dallas. So spent 30 plus years here in Fort Worth in health systems, was former medical director at the MedStar system, and now an associate professor in medical education at UNT Health in Fort Worth.
Good morning, I'm Ali Lehman. I am currently the Executive Director of Mercy Clinic, which is a free medical and dental facility here in Fort Worth. We serve 3 different zip codes. But previously, I have always been in nonprofit healthcare. I am not a medical professional, so I'm not a doctor, but I've been fundraising and working in the national realm in the Heart Association, the Cancer Society, and the March of Dimes. Really not just talking about fundraising for healthcare, but also preventative healthcare, how we educate people to have better health in their life. And it's interesting in all of those national nonprofits, the keys are the same across the board when we're fighting chronic disease.
Good morning, I'm Steve Love. It's a real privilege to be here. I've been in healthcare over 50 years. I worked about 35 years in hospital administration and in finance. But for the last 18 years, I've been at the Dallas Fort Worth Hospital Council, and we represent in a 17 county area over 90 hospitals. And when they come to the hospital council, we're really Switzerland. It's not to compete with each other, it's not to look at market share, it's to how do we help the community? What are things we can do within the community to improve the health of the citizens? So Thanks again. It's a real honor for me to be here.
My name is Stuart Bikel. When I was 5 years old, I told my family I was going to be a minister, a doctor, and a fireman. And I'm fortunate that I was able to do all three, and firefighting didn't stick. But I did go to seminary at Princeton before I came to Texas. Never would have come to Texas. Somebody sent my application here, and then when I came down and checked it out, I actually kind of liked it. But then the medicine thing never went away. So I was a pastor at First Presbyterian Church, associate pastor there. Then went to medical school in Dallas at UT Southwestern. Did a med-peds residency and married a Texan in the meantime, and ultimately came back to start a practice here. So I've been in practice here since 2001. Lived in Fort Worth starting in 1987, but came back in 2001 for good. And so I have a private practice, outpatient practice, which you'll like to hear a little bit more about. And I'm also on faculty at TCU, where I'm a professor of internal medicine and also in the ethics dean lead and past president of the Tarrant County Medical Society, and also medical director of Project Access. So we work with charity clinics like Mercy Clinic to help get them specialty care that the patients need.
You know, we're going to get into a little bit about kind of what your guys' work looks like and how that in turn may help lower healthcare costs over time for patients when we look at their 80, 90, 100-year lives. But I kind of want to talk very generally, and I know this topic is very general, and it's very national. But kind of when we look at the local perspective, because that's what we can influence on the day-to-day basis. Just a blanket question, what is the best way to lower healthcare costs locally? It's the topic at hand. So we'll start with Dr. Bikel and then kind of work our way back here.
Well, I mean, to get the most granular, the way to do it, obviously, is to spend less money on it. But the way I can do it is by being more efficient and responsible in the way I take care of patients. So I think one of the biggest problems we have is overutilization of resources. Patients, it's too easy to just automatically, a patient calls up, says they have a headache or something, send them to the ER, especially if it's later in the day, when there might be, well, there almost always are, more inexpensive ways to manage it. And if it's something you can't do in the office, urgent care is certainly a better option than sending them to the ER. But the knee-jerk reaction historically has always been to send people to the ER. Chronic disease management, I mean, that's huge, but a lot of it comes down to the decisions that the individual physicians make. I think, you know, people talk about how much doctors make. I mean, in terms of income, they don't make that much compared to how much money is spent in healthcare. But all of the money that's spent in healthcare pretty much comes at the direction of a doctor who's managing or ordering or doing something. So I think a lot of it just has to do with the decisions we make at the granular level in the clinic.
You know, I totally agree with what he said. A couple of things, you know, I think most people know when you come to a hospital, hospitals basically 1/3 to 35% of the total healthcare cost. And that's because obviously when you come to the hospital, you're in a state that you're gonna need some kind of very expensive treatment. But what hospitals are looking at, and you mentioned here locally, is how can we keep people out of the emergency room? I totally agree. You can get good care in urgent care centers and other settings rather than come to emergency rooms for a couple of reasons. Emergency rooms are expensive, and secondly, they're very crowded sometimes. You know, when you look at certain times of the year, like flu and RSV, etc., you may not want to go to the ED if you're having a problem that an urgent care center could take care of. Locally, some of the things we're doing, hospitals are looking at ways to reduce cost. I'll give you one good example. I was talking to Rick Merrill. Rick Merrill is the CEO of Cook Children's, and they looked in their emergency room records at how many asthma patients had come in. And a child that has asthma will have episodes, and you may need rescue medication. Now, I'm not a physician, but I do know this. They looked at some of the most frequent return visits of children with asthma, and they actually went out into the homes where these young people lived, and they changed carpet. They looked at the HVAC systems. They made changes. And then they tracked these patients. They had an 80% drop in the readmission of those patients and an 80% drop in the cost. Now, I understand that's kind of a Band-Aid when you look at the total, but hospitals, looking at ways to look at prevention and wellness. You know, as Stuart said, chronic illness is a real problem. People like me, baby boomers, as we get older, you know, many have chronic illness, multiple chronic illnesses. That increases the overall cost. So we all in this together and have to work together.
I completely agree with Steve. I think one of the things that we discount here is the number of nonprofits that are out there doing really good preventative work and education. I think we've got lots of great organizations that are really good at their piece, and the more we see them partner together to really attack some of those things. You know, we talked about a Band-Aid, and when we look at things upstream, sometimes a Band-Aid on the beginning of it can save so much more. When we look at, I believe it was Cook Children's that put out a flyer, and I've seen it from several different hospital systems, when you go to urgent care versus when you go to the emergency room. You know, if you have a cut on your finger, maybe you're going to urgent care. If your finger is off, you're going to the emergency room. But when we look at those with chronic disease, if they don't have access to primary care and someone who is managing that chronic disease, then they're moving into urgent care and then emergency care and then hospitalization, which is the most expensive part of it. So if we look upstream to how we are helping these people prevent and also treat chronic diseases, we solve for having them be inpatients within the hospital and that most expensive cost.
Well, I was wondering why I was here, but now all the attacks on emergency medicine, I understand. No, it's interesting, and I kind of say what Allie's saying here. As an emergency physician, I think the missing piece that affects healthcare in many cases, access and ultimately the cost, is an established primary care provider. Almost, you know, everybody that has insurance has an assigned primary care provider, but when they come to the ER, they almost have no established relationship with that primary care provider. And you look at chronic diseases like diabetes and hypertension, there's decades of disease before any clinical symptomatology really comes. And if you don't go and get established, you're going to show up in my ER and I'm going to do an EKG and it doesn't look normal to me, but I don't know what your normal is. And so the pieces of that. So what do we do at the Health Science Center? 50 years ago, we started the Texas College of Osteopathic Medicine. Osteopathic physicians primarily go into primary care settings. And in fact, the Osteopathic Medical School, TCOM here in Fort Worth, is the #1 producer of primary care physicians for medical schools across the country. And we do that by making healthcare affordable, right? The #1 barrier to people, graduates of medical school, picking a specialty is I got a lot of debt. And what am I going to do to go into? And when you think about the average income of a primary care provider, a family physician versus other specialties, it's significantly lower. And so focusing on that, I mean, ultimately our mission at the Health Science Center at UNT Health is creating solutions for healthier communities. And that not only begins with providers of our physicians, our medical students, our physician's assistants, our pharmacists, but really when you think about public health. I mean, a very small percentage of overall health has to do with health care. It has to do with, like Steve was saying, the environments that we live in, the communities that we live in. If you read about blue zones, we have one blue zone in the U.S., right? It's in Loma Linda, California, right? And it has to do where the average age is 12 to 15 years of the rest of the population. And what is it? It's a community. They belong to a community. They belong to something higher, church very much focused. Their diet, plant-based diet, and people say, well, how is that? Because Loma Linda is 5 miles from where McDonald's was born, right? And so it is really about choices and things we do in creating access to primary care. And you should see your primary care physician when you're not sick, so that when you are sick, they know you and they're much able to manage you in the sense to not send you to God load the emergency department, where you see people like me, which it's a bad day if you see me. But anyway.
We kind of talked about these different spaces within the healthcare system. I mean, can we kind of go into some examples of like what is being done here in Tarrant County and in Fort Worth, where you look at this and say, maybe this isn't a solution for the whole problem, right? But we're taking a chunk out of it, we're taking a bite out of it. Dr. Beeson.
Sure, I'll use our Center for Older Adults as a great example. Dr. Knabel came to UNT in the mid-90s when we really didn't have what used to be called a geriatrics clinic. But what happens in Center for Older Adults is many older adults have very complex diseases. And so how do you get a primary care provider that surrounds themselves in truly a patient-centered style of care? Today in many clinics, you go see your provider and you need labs. Well, you got to go somewhere else and have your labs drawn in many cases. Or if you need any radiology or others, you got to go to another center. So how do you build systems of care really with the patient in the center of that, to where the patient goes one location? So in our Center for Older Adults, we have our social workers there. We obviously have our nurses, our providers. We have our pharmacists that are able to come in and discuss things, right? And then we also have our physical therapists, because mobility and balance and things are a substantial part of keeping people at home. And the longer they stay at home, the longer they live because of healthy mobility and things, right? So purposefully creating health systems. And I think it's really hard to change, and I'm sure Steve will have some comments from the hospital systems, is they're integrating many cases because of the struggles and challenges with reimbursement, with the way the world is in this country. And it's really hard to build systems like that. But when you're in an academic center and you have students from all of the colleges that we have at the Health Science Center, you can purposely build systems of care like that have great outcomes and positive impacts on the patients that we serve.
I would say the free and charitable clinics within this community are amazing. Of course, I work at one, so I happen to love it. But providing that primary care to those folks that do not have access to insurance, keeping them out of our emergency rooms is so incredibly important. There is a wonderful network of free and charitable clinics here in Tarrant County. And it really relies on the medical community to give of their time in many instances. Mercy Clinic operates on, we have one assistant medical director, and everyone else volunteers their time. We have folks that give us one evening a month. We have some folks that give us one afternoon a week. We have specialists, we have primary care providers, we have dentists, we have dental hygienists. If this is something that you would like to do and give your time so that some of these folks do not end up in that really expensive, not that it's bad, emergency room. I spent some time in the emergency room. We would love to have you be a part of this cost saving for our community by helping us provide primary care and primary dental care to those who don't have access to it elsewhere.
Yeah, I really salute a lot of the organizations like Allie's that help. Many people may not know this, but Texas has the highest uninsured rate in the nation. We lead the nation in uninsured. And as a result, sometimes they put off seeking care. And when they do come to the emergency room, and this is an appropriate time, unfortunately their acuity level has increased to the point that it truly is a problem. Especially if you have severe diabetes and you come to the emergency room and you need a toe amputated. That is the wrong time to get treatment. I think what most of the hospitals are doing, and here in the Fort Worth area, let me just say this first to the community. He mentioned blue zones. Believe it or not, we treat Democrats and Republicans in hospitals, so this isn't political. But I really admire what Betsy Price did when she really worked on blue zones in Fort Worth to improve the health of the community. And I know Manny Palka really supports good health and prevention and wellness as well. But I just want to salute the community here that put a real bright light on blue zones and the work that you did and through their leadership. But what some of the hospitals are doing to try to promote health and wellness, they're trying to meet people where they are. If you've got someone that maybe does not have the same education that many in this room have, and maybe they live in a food desert, and maybe they have problems related to transportation, sometimes you have to meet them in the community. So many of the hospitals send vans out in the community to do screenings. And like Stuart and I were talking, you gotta have, if you find a problem, ethically, you've gotta be able to refer them where they can get treatment. And that's when you run into situations where it is expensive to do that. A couple of things that recently came out of DC that I was glad to see when they looked to keep from shutting down the government except for Homeland Security. Two things that really went through that are gonna help. One, we can extend virtual health for another year. So a lot of the hospitals and physicians can use virtual health. I know virtual health can't be used for everything, but it can be helpful in many cases. The other thing that has been extended through 2030 is called Hospital at Home. And many of the hospitals, some here in Fort Worth, it's looking at how you can keep the patient at home and you can use monitors. It's not home health care, it's home health care on steroids up to the point it's like being in a hospital. And I think that's gonna help reduce costs, but I think it's gonna be best for the patient. So these are just some examples of things that we're doing, but we have a lot more work to do.
I agree. You know, we have, for whether it's for political reasons or whatever, we have built a system in the United States of healthcare that is based on volume and complexity, when what we need is value and simplicity. And cutting through all the administrative barriers, there's the way the whole hierarchy, vertical integration and things like this that have occurred in healthcare over the years. I mean, you can look at the evolution of it and it completely makes sense. But it makes it really hard for me. Like when I came down here, I was a solo practice doctor. I couldn't be a solo practice doctor. There are still a few dinosaurs out there. I saw Greg Phillips, he's here somewhere. So there's a few out here that can still do it. But I don't, you know, it was one of those things that for me just became a problem. And looking back, I can say, well, part of the problem was just the administrative burdens that are put on you that make it really difficult to do things by yourself without help. And why should a doctor need that much help just to be a doctor? So at any rate, so I think that the complexity that has occurred in the healthcare system as it's evolved has been a problem. And you know, some of that's based on expediency and just trying to get things done. When they came out with electronic health records, for instance, the priority was getting us to use them. They just wanted us to get on EHR, but nobody required that the EHRs talk to each other. Well, that seems like it might be a problem. You know, if there's 30 EHRs out there and they don't talk to each other. So that's not a whole lot different from just having paper charts. And that's gotten a little bit better for a variety of reasons, but, and I think I'm hopeful, you know, I don't want to be dystopian about AI, but AI has the potential to significantly change healthcare just like it has the potential to change everything else. As far as individual granular things, I'm glad y'all talked about primary care, because, you know, obviously, med-peds. I'm board certified in internal medicine and in pediatrics, so I care a lot about primary care. And I think that's really where the rubber hits the road. I mean, the relationship with primary care doctors is important. But no, not that many people are going into primary care anymore. I'm glad TCOM is still generating a number of them, but I'm a professor at TCU. I haven't met one. I mean, there are some going into internal medicine or pediatrics, but that's just to get into cardiology or gastroenterology or something else. So I don't know how many, maybe there's a few, but if they are, I don't know who they are. And that concerns me because we do need more primary care physicians. I personally think we ought to elevate primary care to the level of a specialty where we're managing teams of providers who take care of patients at a high quality level. So to the point, like several years ago when I was with another organization, and Jeff, you were with MedStar, right? And we set up this thing where you guys would show up every time one of our patients got discharged from the hospital. You know, the Tahoe from MedStar, not the MedStar, you know, the ambulance, it was the Tahoe, would show up to check on a patient who had been discharged with heart failure or COPD to make sure they were doing okay, because it's in that first 2 or 3, 4 days that they're gonna get readmitted. And so it's investing the resources in keeping people out of the hospitals that are important, and that includes creating integrated primary healthcare environments. So one of the things that we did in a practice that I had not too long, but at the same time, is that we did similar to what Dr. Knable has. We didn't have physical therapists, but we had clinical pharmacists. I love clinical pharmacists. Those folks are awesome. You always think of them as being behind the counter at Walgreens. No, these people are in your clinic and they are seeing your patients when they come out of the hospital, and they've got 3 medications that are all in the same class, you know, and somehow they ended up with all of them at home. And so it helps them go through and make sure we don't have medical errors and duplication there. You know, we had social workers, diabetic educators. The ability to have these in the clinic is really, really helpful, because that's what really, and then we can focus on the sickest patient. One of the things we're doing right now, we call them band 4 or 5 patients, just means they're in a higher tier of risk of being readmitted. We see them every month. We want them to come back. They push back sometimes, but the data shows if we see them every month, they don't go to the hospital as often. So even if they're feeling fine, we want them to come in every month just so we can check them out. So there's a few things that we're doing.
I'm gonna go into specific questions for each of y'all, but if any of you guys, if the question's not addressed to you and you wanna jump in, go ahead. I kind of wanna see the interaction. But I've heard a lot of talk about PCP, primary care, and I mean, we talked about how UNT Health and TCOM is doing good work with that, but it's still not enough. And you kind of talked about how we need to do more to kind of push it into potentially being a specialty. But again, that being a national issue, what are some things that we can do locally, maybe Dr. Beeson, Dr. Piquel, that you guys think is a good way to kind of promote this as an important and valuable tool and push maybe students to kind of go into that space?
So I think, unfortunately, Stuart talked about it. I mean, if you're going to be a primary care physician, especially in private practice, like Dr. Phillips is, you got to be a business person. You can't just take care of patients because the complexities of contracting. And I mean, if you had any idea of the complexities of dealing with insurance companies, I mean, one United or Blue Cross or Aetna or whatever it may be, there's tons of different plans within there, and this patient can get this medication because it's covered in their plan. This patient can't get that medication because it's not covered. The complexities are enormous. And so there's great examples. We see it mostly in rural communities. It really comes down to whose problem is it, right? I mean, that's the real problem. Is it the community? Does the community want to own the health of our, of the citizens who live in our communities? Then we will change our response to it. But there's great examples in rural parts of Texas as hospitals shut down because, the financial complexities. They can't recruit primary care providers. So actually the communities, the counties fund these. At UNT Health, we have a great example of a community in West Texas who identifies kids in high school that want to go to medical school. And so we have a partnership with UNT in Denton where they get accepted to UNT in Denton. If they make the grades, they have an automatic acceptance into medical school, knowing that when they finish, they're going to do a primary care residency and they're going to go back to that community. And that's all funded by that community, right? And so then that primary care provider is from that community, and they're taking care of their friends' parents and grandparents, and there's really ownership, which just changes the dynamic of it when you're part of a community, and I think that's missing in many cases. The solutions like that could happen right here in Fort Worth, but I think it comes down to defining who owns the problem. Because I'm not on city council. I see some city council people in there, right? And the financial complexities of running this business, as we know as a city. We know as the county, we have the county health system, the JPS, the Tarrant County Hospital District System, primarily around the unfunded, underfunded, which is the safety net. But that really still has a significant void in primary care. And how do we get these individuals? And so it's a very complex problem, but there's great examples of communities coming together and solving this as a community, which takes the preface or the barrier, financial barrier, in many cases away, because it's a community solution and ownership.
Good job. The primary care, I think, is undervalued. Their role models are not as plentiful in medical school as as other specialties. Again, I actually majored in history, so I like the whole historical aspect of this. You could look at this back to when people talk about the crisis in medicine and people not trusting healthcare because of all the stuff that happened with COVID, but that's not a new problem. I mean, 100 years ago we had the same problem, and that's when the Flexner report came out, and they were trying to get trust in healthcare institutions, and emphasis started focusing not on apprenticeships, but on educating people in hospitals and medical centers and the academic research around it. And that sort of has been perpetuated all through the 20th century, so that when I went to UT Southwestern, which is a very research-driven institution, there were no role models in primary care. I mean, really, for general primary care. Most of the role models I had, or the mentors that I would have had, they just kind of assumed you're going to go into a specialty. UT Southwestern at the time didn't even have a family medicine residency program. I think the first year was the year that would have been my first year in residency. So they introduced it in 1996, but up until then they didn't even have it. So my point is that a lot of times there aren't a whole lot of opportunities for medical students to see healthy primary care practices and make it worth doing. The other thing, of course, is the cost. You alluded to this earlier, the cost of going to medical school. I have a colleague who went to Southwestern back in the 70s, said it cost him $700 a year in tuition. Well, I calculated that out, adjusted for inflation and TCU's tuition, they would last 3 weeks. So a year at Southwestern in the 70s, that would only last 3 weeks now. And the students know this. If they're graduating with $250,000, $300,000 in debt, they're not going to want to go into primary care, which is, we get paid fine compared to the average person. But, we don't get paid what a lot of the specialists do. And so there's certainly that drive to go into specialty care. So, and I think that that's going to hurt us in the future, because if fewer people go into primary care, you're going to end up having a lot more primary care delivered by people who aren't as qualified as physicians. Not that they aren't able to deliver good care, but there are some things that we talked about, keeping the really complex conditions and diseases at home in the primary care setting. And then one more thing I want to say. I know I'm sorry talking a lot, but I'm going to just get through this one thing. Medicare, we talk about insolvency in Medicare and Social Security and all that. When they set that up in the 30s, or no, well, Medicare was in the 60s, but when they did Social Security in the 30s, life expectancy was 66 or 65. We were supposed to be dead by the time we were able to take care of this stuff. We have gotten so good at taking care of people that now you can live with heart failure for 30 years rather than dying after 3 weeks after diagnosis. So that's a credit to our healthcare system, but it has created a significant problem. And because we are so fractured, because we value complexity over simplicity, because we value volume in fee-for-service models over value, we, as a result, are not really taking good care of patients in the outpatient setting, the primary care setting, which needs to be emphasized as a priority.
We also mentioned the uninsured rate here in Texas. In Tarrant County, the rate is about the same. It matches the state rate. I think it's a little bit lower, but it's still around 16%. And the nonprofit space and the health clinic space does a lot of work to try to cover those gaps as much as possible. How much is that need, though, Ms. Lehman, when it comes to like how many more gaps are there, and what can be done? And what else can be done when it comes to that? As an expert in this space, kind of what can we do here?
Sure. So last year, Mercy Clinic provided over 3,000 individual medical and dental appointments. We have a backlog right now on our medical list. If you want just a well appointment, it's going to take you about a month and a half. If you are sick, it's going to take you about a month, because that's how we're managing our practice. The number of people who need our care way exceeds the amount of care that we can give. We know at Mercy that we're on the 3 pillars that will keep us going. One would be funding, and we do not receive state or federal or county funding. We are completely privately funded by donors and local organizations, which is very similar to many of the other free and charitable clinics in the community. Those folks are not getting big government checks. They're not charging their patients, so they're not getting in the Medicare, Medicaid, any of that stuff. So they are working on private donations. The second part is the volunteer base. We know that we can see more patients if we have more volunteers. When our list gets long for that primary care just check with our folks, that means that they are not getting a medication, or maybe they're taking a medication wrong, and that is when they get into crisis and need critical care at an emergency facility. So if we can see more folks on the primary care basis for free at a clinic, then we can keep them out of the medical system. But it's not just the care. It's not just giving them access to medication. We have free pharmacy on site, and so they're leaving with medication from Mercy Clinic. It's also teaching them that you actually have to take it every day, not just when you feel bad. Diabetes and hypertension are something that have to be medicated daily for the rest of your life. It's also what they're eating. It's also exercise. That's why we have a walking program that one of our physicians started. He said, if y'all will meet me at the clinic on a Saturday morning, let's go for a walk. Let's let you walk through your neighborhood and teach you what that looks like. So it's more than just the care, it's also the education to those patients. One of the things that we have started with this community is also just talking about mental health. That could be a whole nother panel talking about access to mental health care in Tarrant County. If English is not your first language and you do not have access to insurance, you do not have access to mental health in Tarrant County. So we're trying to at least introduce, what is mental health and what can you do for yourself personally? Is it, finding a faith-based organization? Is it finding a church home? Is it finding a support group? Is it talking to your family? Is it taking a walk? Just giving them extra tools that they can have to really battle and be their own best advocate in healthcare.
I'll add, when you talk about the uninsured and what we're doing, Stuart is right. We have a very fragmented healthcare system in this country. You've got 50% of it is government funded, and the other 50% is funded privately. And so you have different approaches. It's voluntary. So people don't necessarily have health care. In other countries, you have to have, in some cases, you're compelled to participate in health care and get some of the things in prevention and wellness. We alluded to how many people are uninsured in Tarrant County, and it is a large amount. As you look locally, you're blessed here in Tarrant County to have the healthcare coverage you have, especially with JPS being the safety net hospital. But even some patients don't qualify for JPS, and they have to see Allie or get help. Yeah, they get to see Allie. And what can we do about it? Well, I commend a lot of the hospitals here in the Fort Worth area. Many of you may not know this, but you hear Medicaid is for people who are in lower income. Medicaid in Texas, you have to be a pregnant woman, a child, or disabled adult, for the most part. Some people can get some senior benefits, but everyone doesn't qualify for Medicaid. One of the programs that has been very troubling is maternal mortality. And maternal mortality is when a woman delivers, count or fast forward 12 months. We rank 49th out of 50 states in our maternal mortality. Mississippi's the only state that's worse. Many of the hospitals here, especially Medicaid, would only cover 4 weeks after the patient was discharged. It's now a year, and I thank our state legislature for moving it to a year, because if you can follow that patient and treat them after birth, you can save lives. It's very important. Maternal mortality is primarily all women subject to it, but it's primarily African American women that lose their lives because of maternal mortality. So I think the community realizes that the legislature, the hospitals, the physicians have worked together to try to drive that down.
I just want to tag on to that. I mean, 76104 is the worst zip code in the state, of the 49th state in the country. So it's just to the east of us, or west of us, right? I don't know what zip code I'm in.
We accept questions from our readers beforehand, and one of the questions that we found, I kind of wanted to add to it, so I'll just read what they asked first. Since we are all complicit in healthcare costs in one way or another, can each panelist describe how they are contributing to the growth of these healthcare costs? And I kind of wanted to add to that, because I think working within the system, again, is what we're trying to do to try to find solutions. But there are others who have chosen to work outside the system. I think about like direct primary care providers to try to, again, serve smaller populations, but that's a topic that kind of, they see it as a lost cause. So I mean, blanket question, why is it important to kind of work within the system and try to find those solutions?
I'll go first. It's a great question. Hospitals can do a better job of controlling their costs, no question about it. We can, no matter how much you work at it, you can still strive to do more. You heard in the opening speech, it's great about the healthcare program that's going to be here. Really commend them. But the workforce is expensive. And as you look at some of the clinicians, the price is going up. And there is a shortage in certain areas, so you have to pay more. You heard about what Jeff said about the rural areas, and that's really problematic. We have 150 rural hospitals in Texas, and a third of them have less than 10 days cash on hand to meet payroll. So we're really in a struggle to help those rural hospitals that are very much an integral fabric of their community, large employer, etc. So I think some of the things we can do is, how can we look at our workforce, which is 50% of the expense in a hospital, and how can we minimize that? How can we look at legislators and educating them to let people practice to the top of their license? Just different things we can do. Work on pharmaceutical costs, supply costs, look at ways through our group purchasing to have more purchasing power to help lower the cost. It's a struggle, and I know hospitals are a third of the expense when you look at the GDP, and we've got to look at ways to trim costs.
So I think to the question of working within the system or not, I think that sometimes you have to leave the system. I mean, sometimes the system is history repeating progress. And so when we started the program that Stuart was talking about at MedStar in 2010, when I was the medical director, we first started to find, we were Switzerland, right? We took patients to all hospitals. Hospital A only knew when the patient showed up at Hospital A. Hospital B only knew they were Hospital B, but we at MedStar knew they went to A, B, C, and D every 3 days. And we wondered why the individual glowed, because they were yellow from the 4 CAT scans they got across the week, because nobody talked to each other, as Stuart was talking about. But we started with what resources existed in our community. And when we first started, it was about a 1-inch binder. And when I left 3 years later, it was like a 6-inch binder. There are so many resources within our communities, from putting handrails and ramps in homes to people who do repairs on homes for leaky roofs, to all kinds of things. But we don't know what we don't know. And that becomes the struggle. I mean, I believe that most communities have the solutions to their problems. They just don't know it. And so to innovate, sometimes you have to step outside. I know we have some innovators in the room here that have built wonderful practices and have been examples and are helping patients. And so it's a combination of all those things. I don't think, whether you're red or blue or green or white or whatever you want to be, one size doesn't fit all. And I think that is the struggle that we have in healthcare. We talk about health insurance. I think an important piece is, I'm a healthcare provider, and when I become a consumer of healthcare, my God, how complex is it? And people don't understand that. We talk about, having Medicaid or having, a government-assisted plan that has a very low premium of $25. Well, the government's subsidizing the premium. The first time the individual actually has to use their insurance, they have hundreds, if not thousands of dollars of a deductible out of their pocket. Well, if they can barely afford $25, how are they going to afford $300 or $400 or $500 or $1,000 for a deductible? And so when we say, well, health insurance, Medicaid, and others is a solution, sometimes it is, sometimes it's not, because it's very complex. And so, as Stuart said, is removing those complexities, having community health workers and others help individuals navigate and communicate the things. Health literacy is an important part. I mean, we can everybody in this room can have a small impact in improving healthcare in this community.
Can I jump on to the praise for the community health worker? I know we have multiples in the room, and we also have great resources in the community to get folks trained to be a community health worker. So if you have, think of, and I'm going to clobber this, but think of not a social worker, but someone who's really helping those patients navigate the healthcare system and is asking those deep questions like, hey, we sent you home with insulin. Do you have a fridge for that insulin? You came in and talked to the doctor for an hour. Did you understand the instructions that the doctor gave you and needs you to do when you get home? They ask you to do follow-up care, or where you're being discharged from the hospital and you need follow-up care. You owe this hospital lots of money. Are you gonna come back for follow-up care, or do we need to find somewhere else, a free or charitable clinic that can do that follow-up care for you? So getting someone within your organization, if you are a healthcare organization, trained, certified as a community health worker, is not a really expensive process, and there's great organizations here in the community that will train those folks to do it. It's a great add-on to, we are doing it with our administrative assistants, our patient care coordinator, and now our receptionist is also going to be a certified community health worker, and it's just a wonderful thing to add on to help patients navigate those resources.
I wanted to just actually piggyback on what you had just said about, it occurred to me as we're sitting up here and all of us are involved with healthcare institutions and the delivery of healthcare and that sort of thing. Everybody talks about the statistics about how the United States spends so much on healthcare and our outcomes aren't as good as other developed nations. And I think one of the things that we've been talking about mostly has been social problems, not necessarily medical problems, but they're the social determinants of health that create the health problems, right? And so, and compared to the other countries, I think, you know, and I don't know the statistics on this, I've seen them, but in general, you know, we always talk about how much we spend on healthcare, but the problem is a lot of the money we spend on healthcare are actually social services. Other countries spend them too, they just don't call it healthcare, they call it social services. And so if you looked at how much we spend on healthcare and social services and how much they spend on healthcare and social services, they're comparable. We're not that far off the grid. What does that tell you? I mean, why are we delivering social services through healthcare institutions? We don't do it quite as well, I don't think, through the healthcare institutions as we do if we did it through social services that are set up. So the bottom line, I mean, basically what I'm getting at with that is that we spend an awful lot of money that we call healthcare, which is really social services and the social determinants of health. And we need to really invest more in the social service aspect in order to get people engaged in the relationships with their primary care, get them walking, you know, motion is lotion. It's always nice to get out and move because objects in motion stay in motion. And we want to make sure that we're keeping a healthy population. Blue zones, projects that think that employers, we have large employers here, they have a lot of leverage and power that they could bring to a market, if you're going to use a market economy like that, in order to negotiate better prices and and it's one of the reasons why we have so much vertical integration, I guess, and this is your area of expertise, but you know, all the hospitals buying up a lot of the practices. When I went into practice, maybe 40% of the physicians were employed. Now it's like 80, 75 or 80. And so, you know, that completely changes the dynamic. There's all things we could go into about that, but it does create yet another layer of complexity, which is a concern.
I've been told we have less than 5 minutes left. So I'll ask one more question, and I kind of want to, again, kind of look towards the future. We talked about, I mean, AI was mentioned, but at the same, one of the things I kind of want to reiterate is that the costs are not increasing in a bubble, they just continue to go up, right, when it comes to healthcare costs. So, I mean, in using your magic 8-ball, which I know you all have, kind of how do you see this conversation shifting in 10 years? What do we think is going to happen, and kind of what can we do locally to, again, make sure that that conversation does not mean more people uninsured, more people not receiving care, and making sure that our community stays healthy in the long term and continues to get more healthy?
You know, I'll take a shot at it. You know, when you look at healthcare, as Stuart said many years ago, and then you look at it, there have been a lot of third-party people that have injected themselves into the chain all the way down. You talk about cutting healthcare costs. Does the consumer ever see that? And that's the problem when you have a lot of middle people in it. I think when you look at the problem, 2 out of every 3 people employed in this country are employed by small business. Small business in many ways is the backbone of the economy in a lot of places. And they're the ones that are hurt the most because the health insurance they have to cover is very expensive. And many say, you're gonna have to find your own health insurance or go to the health insurance marketplace. I think the large employers, in many cases, are self-insured, but they turn it over to a TPA, third-party administrator, to handle it. I think the tipping point's gonna come when these large employers say enough is enough. We have got to streamline how this is done, similar to what Stuart said, and we're gonna have to really look at all elements that are costing, whether it be hospitals, physicians, pharmacy, et cetera, insurance companies, denial rates. And I think you're gonna see a shift, but it's gonna hit a tipping point, and I think it's beginning now. 67%, I saw yesterday in a Kaiser poll, of Americans said healthcare cost was the major thing they're looking at in the upcoming midterms.
So I think it's being an educated consumer. We talked about relationship with primary care, but I mean, nobody would go out and buy a car or refrigerator or anything without shopping around and doing some research, and yet that doesn't happen in healthcare. I think the relationship with your primary care provider, if you have chronic diseases, is discussing what the options are and what's the financial implications, what is the lifestyle, what's the side effects of medications. I have a lot of people, one of the primary medications get prescribed in heart failure has such a negative side effect that patients quit taking them. I see that in the emergency department, but they never tell their primary care physician that because they don't want to let them down. And so I think that's having an open relationship, asking questions. I think as providers of healthcare that we need to have more understanding of the financial implications of what we're ordering or what we're doing, for the patients, because we don't want to keep that in mind. We really want to do what's best for them, but we also need to understand what's the implications of what's the best for them and truly have a relationship and discuss the options where it's a mutually agreed upon care plan. And then compliance to that is an important piece. Patients, with chronic disease have to change lifestyles, and the society today doesn't want to change their lifestyle. They just want a pill or they want something to get over, but they want to keep doing what they're doing. And so once again, it goes to community ownership and saying that we're going to do something about it. We're not happy. We all agree that something has to be done, so then we have to do something about it.
When we talk about the questions of what the future and what it's going to be like in the future, and I think a lot of this, we have, like you mentioned earlier, we have leaders in the room. This is going to have to involve policy decisions ultimately. Now, there are things that we can do individually, of course there are, and we need to think outside the box. One of the things, I'm medical director of Project Access. What I do is work with clinics like Allie's clinic, and what we do, because your clinic is primarily primary care, right? And so these patients, what we discovered about 20 years ago is that we surveyed all of the primary care clinics that provided charity care, and the biggest problem we had was that we didn't have access to specialists. I mean, just for simple things like hernias and hysterectomies and things like that kept people out of work. These were the working poor that didn't qualify for JPS, and a lot of them were undocumented. And these are policy decisions that result in people not having access to care. And so what our organization does with Project Access is connect them with volunteer physicians who are specialists, surgeons, who are willing to do the procedures for free, and then we negotiate with hospitals that are able to provide the spaces for these procedures to occur. This is an important service, but it's what happens with this a lot of times is that these patients who don't have access to care in the first place are prolonging or waiting to get anything done because they know how much it's going to cost, and then they get into the system and they have to wait longer because it's not very as efficient as it needs to be. And these problems often, we've had patients that, I'm looking at Catherine because she's our executive director, but who go to the ER with vaginal bleeding just from heavy periods, multiple times for blood transfusions because all she needs is a hysterectomy, but she can't get the hysterectomy. And so what we try to do is connect them with that. But why go to the hospital that many times? This is the kind of thing that drives up costs unnecessarily, is not getting the care at the right time, at the right place. And we've been talking about this triple aim thing now for 20 years, and yet we still have trouble getting at it. And that's going to really require some people making some decisions at a policy level or a governmental level that aren't going to be popular, but that are going to be beneficial for the population as a whole.
No, you didn't. Yes, what they said. But also, I am, as I said before, I'm not a physician. And many times working at a free and charitable clinic, we have folks that say, I can't volunteer for you because I'm not a physician. I think everyone in this room, and I think we've demonstrated that, has some way that they can help attack this. Whether it's even just making your appointment with your primary care physician so that you're not ending up adding to healthcare costs in the emergency room or checked into a hospital. Emergency rooms are great. But I do think, whether it's helping to educate folks, helping to encourage your family to go to your primary care physician, talking to your physician about your side effects from medication, all of these different things, talking to your legislators about how these laws affect you and affect others. Just because you are not a physician does not mean you can't help be the solution to these healthcare costs.
Yeah, I want to say one thing before we end on a positive note for Jeff and emergency room docs. When you need an emergency room, they're great. And I got to tell you, I've been in a lot of states. I'm from Virginia. I know with my accent, you thought I was from New York. But I've been in Georgia. I have been in Kentucky. The trauma system in Texas is the best I have ever seen. The North Central Trauma, we call it the RAC, does an outstanding job. But with the level 1 and level 2 and level 3 trauma centers and our rural hospitals that stabilize people, we're very fortunate to have the emergency medicine we have in Texas. Thank you.
Thank you.
Thank you so much for your time.
Okay, I'd like to give a round of applause. You already did that, but let's give another round of applause to our panel and our moderator. Clearly a really important topic, and again, I think that they left us with an idea that we can all take action as we leave here today. Another way you can take action is Babs Rodriguez, our editor. If you have story ideas, whether they're health related or other topics, please reach out to her and share your topics. We're always looking for engagement from this group. One last thank to our sponsors, North Texas Community Foundation, Mental Health Connections, Real Estate Council, United Way of Tarrant County, Hoffer Walker. And again, I think you saw on the board, we'll be back here on April 2nd for our next Candid conversation. The topic, AI revolution. One other housekeeping note, save the date for April 20th. The Fort Worth report is turning 5, and we'd love to have you all come out and help celebrate. Watch for an announcement on that. And with that, thank you so much. Enjoy your day, and thanks for coming out.